Hello? Hello? Two. 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 Praise. Two. Good. What? What'd you say? Hello, good evening, and welcome to today's Christian Life Seminar. And it's part 2 of Get Your Heart Right. And the first session, the first part was a couple of weeks ago, where we got to learn about healthy lifestyles for the heart. Today is a practical session. So there's going to be a lot of demonstrations, and we're going to learn about how to save lives. And so, without much ado, let's invite Profaite to share a word of prayer. Open us in prayer. Thank you.
Good evening, everyone. Shall we pray? Our Lord and Master, we thank you. This evening again, you have brought us together. We are here to learn, and so we pray, Lord, open our hearts, our minds, help us to be able to learn. Prepare those who you are prepared to come and lead us in this. Give them what it takes to be able to communicate not only the knowledge but also the skills to us. And I pray that, Lord, we will be able to use it to keep our lives and to save others also. We thank you in Jesus' name. Amen.
Thank you very much. So let's invite Christiana Boatma-Wowi. She'll tell us a short story. Let's welcome her with a clap.
Hello, good evening, everyone. Welcome to this session. So we're having this session courtesy of the medical response team. As you all know, or maybe you may not be aware, we have a medical response team in LIC, and we attend to medical emergencies, usually on Sundays. We have a team of doctors and nurses, and there's always a team on call every Sunday. We usually sit at the back, and where Dr. Ayi is standing, those 2 seats there, that's where we normally sit. So in case you come to church and you are not feeling well, or someone is not feeling well, a child has fallen down, anything, just come to those seats. Or alternatively, you can speak to the ushers. They know where we are all the time, and they will direct you to us or get us to help you. We have a sick bay, and it's behind the church hall and the church office. That's where the sick bay is located. We have equipment there. We have a bed where you can lie and relax. We also have like oxygen there as well, and we'll attend to you in a very comfortable place. What else can I add? We are looking forward to welcoming any medical personnel who want to join us. So our doors are open. You're always welcome to join us. Thank you so much. I think that's where I'll end. Thank you.
Oh, a round of applause for her. Thank you very much. Now we know where to go when we're feeling unwell at church. Okay, so let's get right into it. Today we have 2 resource persons. First is Dr. Kwame Ekremet. He's an emergency specialist at UGMC, University of Ghana Medical Center. A round of applause for him. Let's see you. We'll be hearing from him in a bit. And Dr. Maame Ofori-Asumadu, and she is the pediatric resident at the Kolebu Teaching Hospital. A round of applause for her. Yes. So today they are going to be our resource persons. The last time we met, we had Dr. Florence Akumia. Remind me where Dr. Florence Akumia is. Jojo. Kolebu, yes, she's also with Kolebu. So she did preventive heart care and lifestyle. Today, we're getting our hands on these mannequins here. It will be really fun and an experience. So let's invite, with a round of applause, let's invite Dr. Kwame Ekremet to, what are you going to teach us this evening?
This evening, I think we'll be dealing more of basic life support. Basic life support. We'll deal with that. We'll start with that. We'll see how far we can go.
All right. Thank you very much.
All right. Thank you very much. And we thank God for this opportunity to share in these basic life skills that we need as individuals. It doesn't matter whether you're a help person or not. These skills we need to all know. Every lay person is supposed to know this, because when someone collapses at home, you'll be there alone with the person. And you need to know what to do. So that's why it's so important that we discuss these things. And I'm glad that I'm doing this with a pediatrician. And I'm not going to do it alone, because I see more of adults. She sees more of children. So it's good we are doing this together. I think the seats in front are for us, those who are here. So if you can move into the seat in front of you, that's the seat for you. I was complaining and telling my wife that basic life support is hands-on. Unfortunately, we have quite a number of people who are online than are here. You need to really feel the body. Yeah, so those of us here, I think everybody can get a mannequin to play with. So we are so few that everybody can get a mannequin. If you are more, 2-to-1 is what we will do. But for us to do the basic life support, the mainstay, the main component of a basic life support is what we call the cardiopulmonary resuscitation. Big brofo. Cardiopulmonary resuscitation. Cardio is heart. Pulmonary is lungs. So we are resuscitating the heart and the lungs. That's all that there is to the cardiopulmonary resuscitation. Now, do we do this cardiopulmonary resuscitation for everybody that we find to be unconscious or is not moving or something? We need to identify the people or the persons who would qualify for us to do this for. Okay, so we'll look at what they call a cardiac arrest or a respiratory arrest. Now, a cardiac arrest means that the heart has stopped working. It is not that the heart is failing. At times, some of us, we have hypertension for a long time, and then we get to a point that the doctors would say that your heart is failing. Your heart is failing, it doesn't mean that your heart has stopped. But when your heart stops, your heartbeat is not there. That's when your heart has stopped. When you have a respiratory arrest also, it means that you are not breathing anymore. Your breathing has ceased. Or we have what we call abnormal breathing, where you can see someone breathing like this. That breathing is not normal. And at times we will be with people and they start breathing that way, and what we would want to do is get the person to a hospital. In Accra, you'll be in traffic for 2 hours. By the time you get to the hospital, they tell you the person is dead and there's nothing they can do about it. But if you have the skill to do cardiopulmonary resuscitation for such a person, then you can start that and call for ambulance to come home and pick the person to a hospital. So that's why we want to learn this basic life support, cardiopulmonary resuscitation. Now, I mentioned that for us to do that, the person should have had a cardiac arrest or a respiratory arrest. Now, how do we identify somebody who's had a cardiac arrest or respiratory arrest? One, because it's a cardiac arrest, the person will not, the heart beats, the pulse will not be there. So the person's pulse will not be there. Normally, we're able to check our pulses. And we say, we put our hand around our wrist and we say, oh, we can feel our pulse. We can feel our heart beating. When we have a cardiac arrest, that is actually even not the place that we want to go and check for a pulse. But for you, a lay person, you may not even bother about checking for the pulse because you might not know how to check for the pulse. But normally when people have a cardiac arrest, what we tell or what we look out for is what we call the central pulses. Pulses close, we call this one the carotid pulse, around your neck area. Okay? And another one around your groin area, femoral pulse. Those are the things that we will be checking whether it's there or not. But again, as I said, if because you're a lay person, you will not be able to do it. But basically what happens is that you put your hand in the midline, in the neck area, slide to the side. Okay, so in the midline, slide to the side over here, into the muscles that you can feel, and you press very deep there. And some of us are feeling our pulse. Okay, that's how we'll check for it. So not having a pulse is one of the things. Not breathing, because you say respiratory arrest. Not breathing is another thing. Or having abnormal breathing, the one I demonstrated. That's abnormal breathing. Or the person being unresponsive. That means that you tap the person doesn't respond. So those are the things that you use to say that this person would need a cardiopulmonary resuscitation. Do we get that one? Okay. So we'll go straight and start demonstrating, okay, because we don't have so much time. So let's say at home, someone just suddenly shouts and falls down. How do I identify that this patient would require for me to do CPR on him or not? Okay. So I first will have to make sure that whatever scene that I have is safe. Because let's say maybe you live here, you are going home, you see someone by the roadside or in the middle of the road and you say, oh, I've learned BLS, so I'm going to attend to the person in the middle of the road. That is not a scene safe. That is not a place that you should start. So you always have to ensure that the scene is safe. Is there fire? Is there some electric wire there that can electrocute you or something? Is there water that you can slip? Look and ensure that the scene is safe. So you look around and ensure that the scene is safe, okay? Once you've ensured that the scene is safe, then you need to check for responsiveness, okay? So you are coming to check whether this person is responsive or not. Let me probably break and chip in this one. We kind of divide individuals into like 3 main categories. We have an infant that is less than 1 year old. We have a child that is 1 year to puberty. Puberty, they would say that if it's a male, maybe he started developing hair on the chest and in the armpits. If it's a female, started developing breast. Around 10, thereabouts. Okay, so 1 to 10 is a child. After that is considered adult. In this practice that we are going to do. Okay, so for the adult, Maame will talk about the infant and the child. For the adult, we need to check for responsiveness. One of the things that we need to identify to say that the person has a cardiac arrest or not. So for the adult, I approach the person. If I know the person's name, I mention the person's name. Okay, so Peggy, not responding. Then I can tap. See how hard I'm hitting the person. I'm not coming to be, oh, hello, how are you? No. I hit him. Oh. Are you okay? The person does not respond. If the person does not respond, I need to call for help. Because at this point, because this person is not responding, whatever I need to do from here, I need help. If I need to carry the person, I need to tend the person, whatever it is, I need help. So I call for a nearby help. So I can ask, Prof, I need help. Okay, then Prof will come. Okay, when Prof comes, or I can tell Prof that, Prof, call the emergency, or activate the emergency response system. Call for an ambulance. And now the question is, how do you call for the ambulance? What number are you going to dial to call for the ambulance? Any options? 191, option 1. Any other option? 192, option 2. Any other option? 193, option 3. Let's choose one. The answer is 193. That is the one that you see. But now the one on the national ambulances is 112. The one on the ambulances now, you see 112. But what we keep saying is that it's always difficult to get them through that number. I've shared a number with Dr. Ayi. I think he will put it up on maybe the WhatsApp page or something. That number, when you call it, always when you call, someone picks. So when you call that number, they will be able to pick and dispatch ambulance to you. And the ambulance would come, hopefully. Because what you have noticed is that if you bundle a person into your car to send to the hospital, they usually don't get there alive. Because during the time you are bringing them, you are not able to give oxygen. You are not able to do anything. Okay, so it's better you call for the ambulance. One thing that you want the ambulance to come along with is what we call the automated external defibrillator, the AED. Okay, so they will come with something like this. You need this one to continue your resuscitation. And we'll come to it eventually. You need it to continue your resuscitation. So it's one of the things that you want them to come along with. So we came, we checked for scene safety. The scene was safe. Then we checked for responsiveness. No response. Then we call for help. And we asked the help to get the ambulance. And now we know the number to dial. So they've dialed that number. But the ambulance will take some time to come. So before they come, what do you do? Okay. So first, we've checked, the patient is unresponsive. I said we need to check for the pulse. Okay. If you can, you do it. If you can't, you will move on. So as I said, 2 fingers, index and middle finger, in the middle of the neck, you slide to the side you are kneeling, and you press there. You are doing this for 5 seconds, not more than 10 seconds. I didn't say minutes, seconds. Okay, so I check within 10 seconds, I need to identify, within 5 seconds, I need to identify whether the pulse is there or not. Whilst I am doing that, because the other thing that we talked about is that the person will not be breathing, I will check to see whether the person is breathing or not. And usually, you need to expose the chest. You need to expose the bare chest. At times, questions come, whether it's a female, this patient is now dead. You don't care about breast and all those things. It doesn't matter. You must expose the chest and examine the chest. Okay? So, quickly, you unzip, if there's a zip, you unzip or rip the attire. And then, whilst you are checking for the pulse like this, you are looking on the chest. So, you go a bit down and you look on the chest to see whether the chest is rising and falling. Others will put the back of the other hand against the nostrils to feel if there is any air movement. Okay, you can take. When you breathe in and out, you can feel air. Okay, so you do that. Whilst you are checking for the pulse, you are looking on the chest to see whether the chest is rising or falling. Okay? If there is no pulse, you can't feel a pulse, the chest is not rising, you need to do what they call the chest compressions. Now you need to do chest compressions. Any questions so far? We checked for scene safety. The scene was safe. We checked for responsiveness. No response. We called for help and asked that the ambulance be called and AED be brought. Whilst they are doing that, we went ahead and we are checking for the pulse and breathing together. So we check midline, slide to your side, and you are palpating for the pulse. You are checking also to see whether there's breathing or not. Okay? The person is not breathing, there's no pulse. We need to do chest compressions. Prof.
This is assuming that the person is lying down, but the person could be sitting down. So what do you do? Do you turn the person? What do you do?
All right. The best position is for the person to be on a bare surface, hard surface. If the person is on a bed at home, our mattresses are so thick that if you are going to do this compression, it will be ineffective. So if we can get the person onto the floor, it's better that way. You need a bare, flat surface. So if it's in a chair, kindly get the person gently onto the floor, and you do that. That's how come even here, we didn't put them on any tables. We want it to be on the floor. Okay, so that is what you do. In terms of positioning, you bring them to the floor so that you can get effective compressions when you do it. Okay, all right, so if now identify that the person is one, unresponsive, the person does not have a pulse, the person is not breathing, it is a time for you to now do or resuscitate the heart and the lungs. But you start off by the chest compression. There was a question? Okay.
Sorry, please, my question is, you said you check for the responsiveness, and you were hitting the person. Is that how to check?
Yes.
You hit the person.
You have to hit and hit hard.
That's not the time. You are not, no, you are hitting.
I beat it.
Yes.
Hey.
Beat.
Beat the person.
Don't rub. Don't tap.
Beat the person from death, basically. In terms of the kids, are there variations with that?
Okay, so for the kids, for an older child, like we said, just like the adults, for the younger children and the infants, if you know their name, once again, you call out their name. So those are infants who know, so maybe from 9 months, usually when you call them, they'll 10. But if they are younger, the bottom of their feet, you smack the bottom of their feet. You don't shake. You don't pick the child up and shake. We don't shake, we don't hit, unlike the adults. It's the bottom of their feet for the little ones. But for the older children, so 10 and above, after calling the name, you hit as well to try to wake them up. Because we treat, like he said, in the resuscitation, it's just like the adults from that age. But for the younger infants and children, there are slight variations. So another variation is the pulse. So you see that in infants, they usually have like short, stubby necks. So you will not be able to even do the carotid, which is the one in the neck. So you go for the one in the groin, so the thigh area over there, or in between the elbow and the shoulder. So same 2 fingers, you place your finger there in between, anywhere along, typically close to the elbow, you are more likely to feel. So you press hard, like you are trying to press against the bone in there to try to feel the pulse. So adult, older child, you can do your carotid. Infants, younger children with not so much access to the neck, you either do the brachial, that's what we call it, the one in the arm, or the one in the groin. So, yes. And then another thing is, checking for breathing is the same. Everybody's chest rises when you are breathing. You feel the breath against your palm when they are breathing. So you can do the same thing to check whether they are breathing. Yes. And they also do the abnormal breathing, what he was doing. The children also have that. So if you go and you find the child doing that abnormal breathing, it also qualifies for CPR.
All right, so now, okay, there's a question.
Yeah, thank you. So you were talking about the responsiveness and all, and now she just mentioned the abnormal breathing, which you also mentioned earlier. So now I'm kind of a little confused. If the person has abnormal breathing, they are not off. So how do we distinguish between the two?
So the abnormal breathing, when they start breathing abnormally, it means that they are off. Yeah, it means they are off. Until you check the pulse and as you think that the person is still there, but they are not. They are off. So then you need to start your resuscitation. Yeah, so it's part of the things. Unresponsiveness, abnormal breathing, no pulse. Prof.
Sorry, whilst he's walking there, the abnormal breathing, we are not talking about just any kind of abnormal breathing. So not like fast, rapid breathing, no. It was what he was doing. So it's like one breath in a long time, they just take, so we call it gasping. So it's like they are not one breath and then silence. Then another breath like that. So it's,
So if you see that, it's abnormal.
yeah, so it's not like you go and the person is breathing fast, then you start CPR. No. It's when they are gasping for air.
So I recognize that breathing that you were doing. That thing. It happened to me a couple of months back.
Okay.
It was actually a area fellowship, care cell, and we were having lunch. So we were eating and we were talking, and the food went the wrong way, and I started having that kind of breathing. So do you treat it the same way, or how do you deal with that? able to walk around and
Okay.
everything.
Right.
But I
Yeah.
just couldn't
So
take it.
that is choking. And it looks like at the end we may talk about choking. So we'll probably talk about that. But if you have that breathing and you're walking around, I mean, obviously you should have a pulse. You can't have a pulse and not have a pulse with that. Okay, when you're walking. Okay, so we need to do the compressions, right? I just want to demonstrate so that we can all come and take mannequins and do, because we want to be doing. Okay, So when it comes to the compression, how do we go about it? Okay, so we say that your dominant hand, normally your dominant hand, so if I'm right-handed, my dominant hand is the right hand, okay? The back of it, that's the heel of the dominant hand, is what I'm going to use. Not the palm, not this part, but the heel, the back of it. That's what I'm going to use. Where do I place the dominant hand? For the adult, male, okay, so let me say, is the lower half of the breastbone. So the breastbone starts from, it is in the center, all the way it comes down here. So all this is the breastbone. For the mannequin, it will be from here to there. Okay, that will be the breastbone. Okay, this part is the breastbone. The lower half of it, so that means that if I divide this into two, the lower half is where my dominant heel would go to. Okay, that's where my dominant heel will go to. So I put the dominant heel over the lower half. In a male, you can use the breast, the nipple as an imaginary line where it meets that bone. You can put your dominant heel there. Okay. In the female, you may have to, where it ends, you may have to put 3 fingers above that. Where it meets, you put your hand there. Okay. That's for the females. But the males, you can use the nipple line to do that. Okay. All right. So I do that, and I put my dominant heel there. Dominant heel. Then I will lift the palm. I don't want to be compressing with the palm. And then I'll support it with the other one, interlock it with the other one, like this. Okay? That's what I'm going to do in the lower half. Then I need to lock my elbow. My elbow cannot be bending like this when I'm doing it. It won't be effective. It needs to be straight. And I need to be very close to the patient. And my whole body over the patient like this. Okay? So this is the position I'm going to assume to do the compressions. So that I said I'm not going to be doing like that. It's straight. So when I come, my whole shoulder, my whole body is what comes on this patient. Okay? Like that. Okay? That's what I'm going to do. Now the question is, how deep do you press on the chest? There are figures, there are numbers and all that. I don't know, but let me just mention it for mentioning's sake. If it's an adult, they say you press at least 5 centimeters, not more than 6 centimeters. At least 5 centimeters deep, not more than 6. If it's a child, like these two bodies here, child, that's the more than 1 year to 10 years, thereabout, you press approximately 5. Approximately 5. The adult, we said at least, but not more than 6. For the child, approximately 5. Then for the infant, the one lying over there, I think she will tell us the variation. You are not coming to put your 2 hands. No, she will tell us. You just do fingers. She will tell us about that. So let's concentrate on these 2 people. Okay? So even this one, you may just use a hand. Depending on how big the child is, you may just use a hand and not support it with the other one. Just one hand like this for the child. You may use that one to do it. Okay, but for the adult, let's go. So I'm going to go deep. That's all that matters. I need to go very deep. How fast do I go? They say that you should do at least 100 to 120 compressions in a minute. That's why you need to call for help. Because this one, you can't do it all by yourself. You need help. It's not food that you want to eat everything by yourself. You need help, okay? So you need to call for help because you will get tired and someone would have to replace you. So, okay, so the 100 to 120 in a minute is there. But also we talk about doing 30 compressions to 2 breaths, giving breaths to the patient. So you do 30, you go 30, so you have to count and count aloud. Okay, so I will count and count aloud. Okay, and there's, the rhythm that it should go. I don't know the song, but staying alive, staying alive. I don't know the song, so if you know the song, you can sing and I will do it. Okay, so that's how we are going to go. So dominant heel over the lower half of the sternum, my elbow locked, my shoulders over the patient. I'm going to go 30 compressions. Okay, so I go 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. Okay, we'll talk about the breathing aspect, but then you stop and you do the breathing. You do 2 breaths, then you come back and you do your 30 compressions. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. Then I stop. Then I come and give 2 breaths. So that's what we are going to do. We are all set. We are all okay. No questions about that. So everybody should take one mannequin. Okay, give us the variation in the infant.
So the variation in the infant, so the child, like you said, older child, you do the same thing. For a smaller child, you can use just one hand, the heel. And for the infants, there are 2 options. You can either circle. So for the infant position, you are going to go below the line that crosses the nipple. Unlike the adult and the older child, where you are going to go at the point where the line between the nipples meets the bone in the middle of the chest. So for the infant, you still imagine that line and just go about 2 finger breadths below that. So just below that line. Okay, just below. So let's assume that this is the nipple. This is the line. You're just going to go just below it. Please try not to press on the end of the bone, the middle, the sternum, that's what we call it, the middle there. Try not to press on that. It will break. Yeah, and you're not actually going to be compressing the heart. So just a line between the nipples, just go below that. So you encircle the chest like that, and then you place your thumbs across the front of the chest like that. So that's one option, and then you are going to press like that. But the child is on the floor, not in your arm like this. I'm just showing us what it will look like. So you are going to be pressing like that. Same rhythm. And you are going to count out loud. 30 is to 2. So you have to, so counting out loud helps you to maintain your rhythm. If you don't count out loud, you'll be pressing at different rates. But when you count out loud, it helps you to maintain the rhythm. So this is the first option. Second option is 2 fingers. Same position, 2 fingers, and then you press. Some people find it easier to do it this way than doing this. This one is sometimes a bit hard to do. But you can use 2 fingers, same position, and then you press. Same rhythm, same rate. Okay. So I think that's the variation.
Okay. Elaine.
I just want a little clarity. For the 2-finger one, you had said earlier that we shouldn't press directly on the sternum. So then where do we place it?
There.
Okay, so there's a little, the bottom of the sternum, not directly on the sternum.
So just at the
There's a
tip over here, there's some small
protrusion there. That's the one you are not supposed to press on.
So go a bit more on the breastbone.
Yes.
Exactly. Go a bit more on the breastbone.
Yeah.
Yeah. So that's what she's talking about. And if you, the more down you come, you
So there's a picture.
Okay, you press on the stomach, and then the content of the stomach
Will come out. Yeah.
mouth, and then move their hands.
So just stay, so same nipple line, just below it. But for the adults and the child, it is the line between the nipples. Yeah, that's
All right.
the difference.
So now that we've seen this, it's time for demonstration by you. You need to ensure that you know how to do it, because it's easy to see you do it. Oh, I've gotten it. No, come and do it. So that we know that you've gotten it. So please, everybody should take one mannequin, and then we'll all go through doing the compressions together. Are we okay? There's the aspect that the online people will not participate. So those of us here, please, let's all take a mannequin.
I think I was going to ask about the breathing aspects. Would we be practicing that? Oh,
Let's do the compressions, then we'll do the.
okay.
So please choose a mannequin. Please choose a mannequin, and then we can always share. So if you choose a mannequin, we'll be fine.
Yeah, if, we can do 2:1, and
Yes.
you take 10. So please.
No, so please let's all just choose a mannequin, and then we'll go through everything we've just said. But just so that you remember, you may hear "Staying Alive" in the background, just so that you remember the counting.
Please, we can do 2:1. So if you don't have a mannequin, you can share. Yeah.
The next thing we check for is what? Responsiveness, isn't it? Responsiveness. So how do you check for responsiveness? How do you check for the responsiveness? Okay, if you know the name, you call the name. If they respond, fair enough. If they don't respond, then you can tap him, and then you tapped, and the person is not responding. What is the next thing you do? The person is not responding. The next thing is call for help.
Call for help. You need
Call
to
for
call
help.
for help.
The person is not responding. You have to call for help, isn't it? And you are calling the ambulance. What number are you going to dial? 193 112. Okay. And another number that we will say, which is more effective. Yeah, that one is more effective. So you call for, and you are asking them to come along with what? The AED. The AED. Automated external defibrillator. AED. AED. Then we know that we are going. Aha. So we asking for the AED. Okay, so the ambulance has received the call. They said they are on their way. So what would you do next? Check for the pulse and the breathing together, isn't it? And it should be more than 10 seconds. Within that 10 seconds, you have checked for the pulse and the breathing. Okay? So check for the pulse and the breathing. Let's go. Let's check for the pulse and the breathing. You are checking for the pulse. You are looking on the chest to see whether the chest is rising. At this point, you should have exposed the chest. So if your mannequin is in the dress room, remove, unzip, so that you can see the bare chest. You want to see the bare chest. So you are checking for the pulse. The pulse is not there. The patient is not breathing. What is the next thing you are going to do? You are going to do your compressions. Okay. So your dominant heel over the lower half of the sternum. Your dominant heel. Everybody should place their dominant heel over the lower half of the sternum. We are coming around to see. So it's always, when you're doing this compression, it's always good to be by the side. So you just be by the side. Exactly. Exactly. Be by the side. Okay, so we are going around checking, and just to make sure that, good. Everybody's dominant heel is in the lower half of the sternum. Okay, and support it with the other hand. Lock your elbow. Yeah. Stiff, straight.
And make sure that you are over the body.
Over the patient. So draw close to the patient and be over the patient. and be over the patient. Are we all okay? Are we okay? Is your elbow locked?
Yeah.
Good. So now we are about to go 30 compressions. So if you are 2, you do 30 and another person will also do 30. Okay, so we are going 30 compressions and we are going to count. So you will count aloud. I'll help you count aloud. So are we all set? Let's go. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Let me stop.
So you need
Press
to
till the mannequin makes a noise.
the mannequin must make a sound when
So
you
let
press.
me demonstrate so that you see this, you hear the sound. So this sound should come. That is when I know that you have pressed deep enough. Other than that, it's shallow. Okay? Other than that, it's shallow. So we are going again. You are starting.
Okay, so again, before you start, so when you are compressing, don't bend your elbow.
Not at all.
That's why you should make sure that you are over the body. So this way, over the body, and 1, 2, 3. So your hands will not bend. You just go straight down and up. 1, 2, 3, 4, 5.
Yeah. Okay, so we are about starting.
So ready?
No false starts. We are all starting. And we are going to 30. Are we ready? Are we ready? Your dominant heel over the lower half of the sternum. Your elbow locked. Your shoulders well over the patient. Let's go. 1, 2, 3, 4, 5, 6, 7, 8,
We
9,
want to hear you
10,
count.
11, 12, 13,
I want to
14,
hear you
15,
count.
16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. What was the experience? It's very easy, huh? It's not easy at all.
Please don't lift your
And that's why you need to call for help.
Yes, don't lift your hand off the chest. You are not lifting and pressing. Your hand should be in contact with the chest all the time. Yes, you are
Okay.
not lifting your hand and placing.
So don't take your hand completely off. Okay? However, you should allow the chest to recoil. That's what we call it. So let the chest come back up. Then you press again. Come back up. Then you press again. It's like you have the heart there. The blood, once you press, let me use this thing. So we are assuming that you have the breastbone that is on top. Okay, that's the one you're going to press. Your spine is behind. And you are squeezing the heart between the breastbone and the vertebral bodies behind, or the bone behind. So you squeeze like this. The blood in the heart moves away to the brain and to the heart. Then you squeeze again, you relax, and blood comes back into the heart. So if you squeeze and you are still down there and you squeeze, there's no blood that has come back into the heart. Okay, so when you squeeze, allow the chest to recoil, then you squeeze again. You squeeze again. You squeeze again. Okay, that's what we are trying to do. We are trying to move blood around the body because our heart has stopped. So we are doing the work for the heart. Okay, so that's what we are doing. Okay, so we are going again. We'll do 3 times, then we'll swap. Okay, so yes.
Our dear friends who are sitting now, you can join us. We can all share.
Oh yeah, we can share the mannequins. I mean, there's no need to.
Okay.
Does it matter which part of the body you are standing? Because we think that the heart is here. So if I'm standing here or there, does it really?
It doesn't matter because your dominant heel goes to the center of the chest, not to the right, the left side where the heart is. If you move your hand towards the right side where the chest is, you have ribs there, and you will break all the ribs there. And they can puncture the lungs and cause another problem that we don't want. So let your hand be in the center, not to the right or to the left. No, be in the center. So it doesn't matter where you are kneeling, whether left or right. You can still do the work well. Okay, let's put our dominant heel over the lower half of the sternum again. Are we there? Okay. Our elbow locked, our shoulders well over the patient. And we are going to go again. Let's go. 1, 2, 3, 4, 5, 6,
We want to hear
7,
you count.
8, 9, 10, 11, 12, 13, 14, 15,
Yeah,
16,
good.
17, 18,
Let's hear
19,
you count.
20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. You are doing well. You are doing well. You are doing well. This patient will survive. This patient will survive. You will die. Let's go the last time. Then we will continue with the breathing aspect. The last time. Again, your dominant heel over the lower half of the sternum. Your elbow locked. Your shoulders well over the patient. Well over the patient. Are we ready? Are we ready? Go a little bit. Yeah, good. Yeah, are we ready? Let's go. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. You have done well. You have done well. You have done well. You have done well. If you haven't done one, it's your turn to do it now. But those of us who have done it, we can take our seats. If you haven't done it, I'm with you. We are going to do it.
The elbows and knees are crying.
Okay, those who are ready to go, are you ready? We can just do one for you. If you haven't done it, we can just do one for you.
If anyone wants to do it,
Yes.
because you didn't get a chance, we can go through it now.
So BLS,
So
the
that we
main
all
thing is the compressions. The main thing is the compressions. So everybody should be able to do the compressions. Those upstairs, they didn't do the compressions. Nana. Okay, so, all right, are you ready? Are you ready to do your compressions? Okay, all right. So your dominant heel over the lower half of the sternum. Okay. Your shoulders locked. Your elbows over the patient. Let's go. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. You have done well. You have done well. Okay, there's a question online.
There's a question online that says, is it regardless of the weight of the person doing the compression? It doesn't matter what your weight is. It does not matter how small you are, how big you are. No. The aim is how deep and how hard you push.
Right.
It's not about your weight. You are not necessarily using your weight. Do you understand? So it doesn't matter. Yes, it doesn't. You don't go and look for the most muscular person in your house to come and do it. And you say that I'm too skinny, so the person is lying there, then you are standing. No, anybody can do chest compressions. It may be harder for you to do, but anybody can do chest compressions. Please, are there any questions so far?
All right, so we would move on, and because we said there's compression, the compression basically takes care of the heart, isn't it? We say we are doing cardiopulmonary resuscitation. So the cardiac aspect is doing the compressions. Okay, it's doing the compressions. Now, when it comes to breathing, that is resuscitating the lungs. We need to breathe for the person because the person is not breathing. So now we need to breathe for the person. Okay, and before you can breathe for the person, there are tubes that connect from the nose, the mouth, down into the lungs. And that tube, it must be aligned. We must kind of open that tube, because if something is blocking that tube and you want to put air into the lungs, it won't go. Okay? So we must first align the tube, then we can give the breaths, and the breaths will go into the lungs. Okay, so we need to move the neck a bit, okay, to be able to do that. I will just talk about just one of them that we call the head tilt and chin lift. Head tilt and chin lift. Okay, so this patient, for instance, is lying there. I want to give breaths, but if the
Hello.
All right. So whilst they are doing this, okay, so we need to open the airway first, then we can give our breaths, okay? So how do we open the airway is one of the maneuvers that we are learning. It's what we call the head tilt and chin lift. With your palm, so if I'm kneeling on this side, my left palm, I place it on his forehead, okay? And I push the head backward. That would be a head tilt. Then with these two fingers, I can hold the chin and also support it this way. That's a head tilt, chin lift. Okay, are we okay? Can we see that? With that, we are able to align the airway such that it can easily get to the lungs, because we want the air to get into the lungs, okay, so that oxygen can get into the lungs. So that's what we are trying to do. Do we get that? Okay, so that is one of the things that we need to do. After we've done that, we need to give the person the breath. Now, we are assuming you are home. You don't have any oxygen. You don't have anything. But we are able to breathe into this human being, just like God breathed into man and man became a living being. We are going to breathe into this human being. The question that comes is that, don't we breathe out carbon dioxide? That's the question, okay? The air that we breathe in, 21% is oxygen, okay? When we breathe in that air, we use just about 4% of it. So it's left with another 17% that is not used. The oxygen that we bring out, about 17% of it is oxygen that is not used. So that means that you can give that oxygen to another person. That's how come you can breathe into another person. Okay? So let no one deceive you that you are giving carbon dioxide. It's not true. We are breathing, and the air that comes has some oxygen in that. So that's what we are going to breathe into this person. Because we are home, we might not have these things that the hospital would use when you are in the hospital. If you are in the hospital, these are the things that we will use. We won't go there because we are not in the hospital. We are home, or we are in church, and we don't have these things, okay? So if you are comfortable, the person is somebody who is related to you, you are comfortable doing what they call the mouth-to-mouth, you can do that, okay? You can do that, but the risk of infection is also there. The reason why, if you don't know the person, it's not advisable to do for the person, because HIV is there, hepatitis B, C, all sorts of infection, okay? Because secretions can come into your mouth from this other person's mouth, okay? So if you're not comfortable, you can just do your compressions only whilst help is coming. Because when the ambulance comes, all these things are on board, okay? So they can come along with that. So you can just do your compressions only. However, if you are comfortable doing that, you do what we call the mouth-to-mouth, okay? So again, because you are going to give air, you must open the airway. This is how we are going to do the mouth-to-mouth. With the border of this hand over the forehead, these two fingers, the thumb and the index finger, will pinch the nose. Because if I'm going to blow air here, and the nose is not closed, the air will come through that nose out. It won't go down into the lungs, okay? So I do this, pinch the nose, use these two fingers on this other side to open the mouth, okay? I can again use that one to open the airway, as we described. So we do this, we open the mouth. Then I take in deep breath, okay? I take in deep breath and seal the person's mouth with my mouth, okay? Ideally, we should have come to with something to cover this mannequin that is Amansan mannequins. Okay, so I will just show it. So I do the hold it and then occlude like that, and I will take in deep breath and I will blow it into him over a second. All that I want to see is the chest rising. That's all. You don't want to give excessive air because it also has its own effect or side effects. So that's what you want to do. The other thing is that we have what we call a pocket mask. It looks like this, but there's a valve over here that prevents any secretions from the patient coming through to your mouth. Okay, this does not have it. I mean, this is not the typical pocket mask, but it's shaped just like this. If you have one of that, what you do is that you see how it's shaped. It is tapered here, it's broadened here. This tapered part goes to the bridge of the nose. So it goes to the bridge of the nose, and the broad part comes over here. It covers the nose and the mouth. So the size should be appropriate, because some of them are too small to cover the nose and the mouth. You need one that will cover the nose and the mouth. So it goes like this, and this one is good for this patient. You hold it in place with this. Again, this one will hold this one in place. This one will try to occlude this part, because there must be a good seal. And then if you blow, the air will leak from here outside. It won't go into the patient. So with this, you hold again. You can tilt this way to open the airway. And again, you take in a deep breath, then you blow it through this one. Did you see the chest rising? Yes, that's what you want to do. I'll do it again. I take in deep breath because it's 2 breaths. I take in the deep breath again, and I blow it into this patient. And the chest rises. And I'm done with that. Then I come back, and I'll do my compressions again. 30. When I get to 30, I count up to 30. When I get to 30, I stop and come. With this thing here, I hold it in place, open the airway, and I blow into this patient again. And the chest will rise. Okay, so that's what I keep doing until the help comes. Do we get that one? Good.
Okay.
Now for the infants.
So the variation in infants, for the child, same as adults. But for the infants, you would form the seal over the nose and the mouth. So your mouth will go over the nose and the mouth. So that's the difference.
Do you get it?
You get it.
Yeah, so your mouth should cover the nose and the mouth.
Yeah.
Just like I was using this one to cover the nose and the mouth.
Yeah.
But when it came to the mouth for this one, I just blew into the... Yes.
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 And then you look for the chest rise. But for the older child, you can pinch the nose and then breathe. And then for the infant, you are not going to push so much air. Like you said, excessive air can cause problems.
Yeah.
So a little, just enough to get the chest to rise. You don't have to overdo it. So I think about your, how do you?
Mouthful.
Yeah, like a mouthful.
Yeah.
Your cheeks, a mouthful should be enough to cause chest rise. So if you do the first one and you realize that it wasn't enough to cause the chest rise, you can increase the pressure the second time. But don't do it too forcefully, even for the adults, because it can cause problems. But if you have a mask appropriate for the child, then you can use it.
Yeah.
But if you don't, mouth over the nose and mouth. And then for the head tilt and chin lift, for the older child, you can do it. But for the infant, if you tilt their head
Too much,
it will kink their airway and you won't get any air into the chest. So for them, you can keep them what we call sniffing position. So just a little tilt, just a little. The head will still be in a straight line, sort of, but the nose is just pointing up a little bit. So it's not like that. When you do that for them, it will kink their airway and you will not be able to get air into it. So we just do the sniffing position. So just a little tilt of the head. In the hospital, we do what we call a shoulder roll. So we put
something at the back
to
shoulder
help us
blades.
get that position. But at home, you can just tilt the head a little bit, just to get the nose pointing a little upward, and then you blow into it. So but you open the mouth. You open the mouth like you would in the adults. So that's the variation. Another tip is for children, their Reasons why they would go into cardiac arrest is mostly respiratory in origin, rather than heart-related
Cardiac in
problems.
adults.
So as you are opening the mouth, you look to see whether there's anything blocking the space. If it's something that is just out here that you can scoop out, fine. But if it's too far, don't attempt to take it out, because you just push it deeper than it already is. And then if you have, I know for the infants, sometimes we have these suction bulbs at home. There's bulb syringe that we use for their noses. So if you open and then you see that maybe there's a lot of mucus or phlegm or water or something, and you have that on hand, you can just quickly suction the mouth, just take it out to clear the airway. But if you don't have it, don't worry, just go ahead and do your resuscitation.
All right. Any questions? Okay. All right. There are about 3 questions. So, yeah, I think I have questions.
So you showed us what can be used to cover the face and the nose, the mouth and the nose.
Yeah, pocket mask.
And then you also mentioned the suction bulb. Are there things that we should have at home that can be handy and may not be expensive, that it will be difficult for families to get?
So most people come home from the hospital with their babies with the suction bulb. I think it's part of the kits. When you are going to deliver, it's usually parts. It's not something that you have to, it's not really a part, because if you go and meet somebody outside in the street or by the poolside or something, it's not something that you typically have. I'm just talking about the home situation where you're at home and you have it on hand, you open and then you see that there's a lot of fluid in the mouth. You can use that to help you get it out. For the pocket masks, some first aid kits.
So at times some people have it in their car.
Yes.
They carry that along in their car. Anywhere they go in a situation, they can easily reach out for it and use. So the pocket mask, some people have it. Yeah. If you have it, it's very good. You can use it anywhere. Yeah. And I don't think it's that expensive. I need to check the price, but it's not that expensive. I will need to check with
you
some
can
people.
get, in terms of pocket masks and all, you can get some in the pharmacies.
Okay.
So if another thing about the children, if you, it's better now. in the children, if you've had a child who keeps having this respiratory difficulty breathing, and so you rush to the hospital, you realize they do a nebulizer, so they put a mask.
Yes.
Some people in the end buy their own nebulizers.
Yeah.
So their nebulizers will have masks appropriate for the child, and they are just the same as what you can use as a pocket mask for the child and all. I think the last I checked for a pocket mask at NS Chemist was like 45 cedis for an adult. So I think it's still available.
It's reasonable.
And you can still get one in terms of on your own. A lot of your doctors will have, mine is in my boot. A lot of us will have theirs available with them, and you can get one as well.
But please don't let this delay you. So don't say,
I don't have it, so.
It's in their room. Then you leave the child, you are going to look for pocket mask or bulb syringe. No, please. Do what you are supposed to do. Don't leave the person and say, I'm going. That's why he said, if you are comfortable doing the mouth-to-mouth, please do it. Don't say, let me go and get my pocket mask. It's in the car, then your car key is somewhere. Yeah. By the time you come, the person is gone. Yes. So time is of the essence. In CPR, time is of the essence. So you don't waste time at all. So all these things we are mentioning, they are just extras. If you don't have them, like he said, if you are not comfortable doing the breaths, do your compressions till help comes.
I think there were 2 more questions over here. If we can clear them, we can continue. Please, you can sit.
I know that you can look for pulse with your 2 fingers here.
Okay.
But you didn't mention that. Is
Yes.
it wrong?
Yes, yes. So I said that we have what we call the central pulses and peripheral pulses. The radial pulse is a peripheral pulse. When someone is in, or we are evaluating for a cardiac arrest, that's not the place we want to go. We want to use the central ones, because at times people will have, their heart is beating, but you can't feel their pulse, and it's not that they have a cardiac arrest. It's just because their BP may be too low to palpate the pulse, and it's not a very good, a sensitive place to check for the pulse in a patient that you're suspecting has a cardiac arrest. So it comes to the central ones, the one in the neck, carotid pulse, or the femoral one, and for the infants, the brachial one as well. Okay, so those are the places that we would want to check for the pulse, not the radial one. Okay, all right. Now, if you are alive, you are checking for your pulse normally, that one you can check it. This is in the picture of a cardiac arrest. Yeah, when you suspect a cardiac arrest. Okay, all right. I think there was a question here. Okay.
There was a cardiac arrest I saw on TikTok. They didn't do any of what you did. They were rather hitting. So is that also good?
So after they hit, did they do anything? And the person woke up. We don't know that one. We don't know that one. That is a TikTok resuscitation.
TikTok can be funny at times, so please watch what you consume. There's good content and there's content for money that doesn't make sense sometimes. So just please be sure about what it is. There's a question online, so maybe I'll read that.
Okay, after. Okay.
Yeah, so it says, growing up, I've seen parents suck out mucus from the mouths of their children and infants. Is it advisable to do that with the mouth for an infant if there's liquid in there?
So the question, if I'm getting, is if there's liquid in their mouth.
Yes, so if there's some secretion in the mouth, is it advisable to use their own mouth to suck it out?
I think it's going to be difficult because you will not be able to get that suction because the mouth, the area is large. So,
also, is it advisable to suck with the mouth for the infant? That's if there's liquid in the nose. Okay.
In the nose.
So I think the person is asking if there's some secretion in the nostril and they have to suck it out because they've seen us, parents have done that when some of us were younger. And so is it advisable to still do that
it's not what is recommended to be using your mouth because I mean all sorts of things, the same way we are saying transferring infections and all of that. So I wouldn't say that you should do that. I wouldn't say that we should do that.
All right. My question has to do with the use of the, is it pocket mask?
Pocket mask, okay.
When you were demonstrating the first one, you did the tilt and then open
the airway.
You held the chin to open up. Now, when you did this, so supposing the person's mouth is closed and then you go and put this thing on it, it means that it's not open. So how do you get the air in? Do you have to open it before you put the pocket mask on the nose and the mouth so that there's still space there for the air to get in?
So at least this one, it covers both the nose and the mouth. So even if one side is blocked, the other side would go. And because the air is going on through both holes, it will definitely go. The other one, we needed to occlude one so that our mouth will go through one and then the air can go. Okay. As much as, I mean, it's at times difficult. You try as much as possible, but the teeth are together, they can't open well. It will go through the nose and it will go. At least we know that it won't come back out from the mouth. It will still go. Okay. All right.
Yeah, so let me just reiterate this. So in the BLS, that's taking out the secretion step is not necessarily a step. Please, we understand. It's not like, okay, so A, check for responsiveness, 2, when you open the mouth, suction, no. In a hospital setting, we may do that.
Yeah.
But for bystander resuscitation, it is not a step. It was just like an extra in case you have, but it's not something that you should should be part of your steps when you are trying to save lives. Please, I hope that's clear.
Yeah. Okay. So, is there another question?
Yes, I wanted to find out what the alternative is if you don't suck the mucus from the nose and you have no suction bulb.
Yes, so that's why I'm saying that it is not a step. So just give your breaths and do your chest compressions. Yes, just do your breaths and do your chest compressions. It's not a step. You actually don't have to stop, like I said, and try to do all those things. No. So just focus on your chest compressions and giving the breaths. Those are the two important things that you have to do.
Okay.
Kwame, you said that for younger children, it could be that he's choked on something. So when you tilt back and you find something in the mouth, then you could...
No. So what I was saying is when you tilt the head too much in the younger children, instead of the airway straightening out, opening up like in the adults, it will rather kink.
It goes too much and kink.
It will kink, so it will bend, so it will not be patent. We'll go to choking, what you do when a child is choking or an adult is choking. We'll do that one.
So probably I'll wait for that.
Yes, we'll do choking.
But the other question is that what do you do when after blowing air into the patient, the chest does not rise?
Okay. So it would mean that it wasn't an effective breathing that you did. But you will not stop. I mean, you just go ahead. If you've given the first one, it wasn't effective, you give a second one. Now there's the time for a second one. You do the first one and a second one. After that, if it's still not, you just leave it and go back to your compressions. As I said, the compressions is most important compared to this breath that we are giving. So you did 1, 2, it's not working. Go ahead and do your compression and look at why you didn't get the chest to rise. Is that you didn't open the airway well, the reason why you couldn't get the breath into the chest. So then when you come back the next time, you try and open the airway better, and then you give your breaths. But once you do 1, 2, go on and do your compressions. I've been signaled that our time is running quite fast, and we need to talk about the AED before we end.
So just one last one.
And the choking too.
Okay, I wanted to find out, should there be a time difference between the compressions and the breath that you give?
No, so you are doing the compressions 29:30. Then I come here, I hold it in place. Then I take in my deep breath. Then I blow. I open the airway. It's not even coming. 1, 2. Then I come back.
So
okay.
It's continuous.
It's continuous. If you are alone. If you have another person, the other person will be doing the breaths, then you are doing the compressions. But if you're alone, you do that and come and do the breaths, come back and do the compressions. You need help. Remember. All right. So let's move on and do the AED right now. So you are doing this 30 compressions, 2 breaths, 30 compressions. Now the ambulance come with the AED. Now this is a trainer AED. So the automated external defibrillator. This one, it comes. When it comes, it means that definitely another person is the one bringing it. So when it comes, you don't all of a sudden just stop the compressions. You continue doing your compressions and everything. Let them operate this thing whilst you continue doing the compressions. So when it comes, the first thing that you need to do is to power it on. Put it on. That's the first thing you do. The second thing you do is to obey its commands. That's all. So you power it on. The next thing is to obey its command. It will tell you things to do. You just have to follow and do it. Okay? I don't know, maybe this one we need to come around a bit so that we can hear it and see. So please, let's come around this mannequin. Okay, let's all come around this mannequin. All right, so quick one. So this is the AED. Different AEDs have different ways that they are powered on. At times, some of them, once you open the lid, it's powered on by itself. Others, you need to punch a button to power it on. Okay, so this AED, so it comes, by the time it comes, you are doing compressions. Yes, the other person should power it, should do all that. So he opens it. I need to deactivate. Okay.
Apply pad. Plug in pad connector next to flashing light.
So did we hear what it said? Okay, to say it again.
Apply pad. Plug-in connector.
Apply pad, plug-in connector. That's what it's saying. So it has these things we call the pads, these ones. And if you look on it, it shows you exactly where it should go on the body. So if you look at this one, it shows that it should go to the right side below the collarbone over here. So we place it over here. Okay. The other one goes to the left side. Okay. You just look at the image and you put it there. It looks like it's below the nipple over there. So
Insert connector firmly.
so we've applied the parts, but it said we should insert the connector. This is the connector. It hasn't been connected, so we need to insert that.
Apply pad. Insert connector firmly.
Okay, so I would insert it. They talk about to the flashing light. So this is where the flashing light is. So I would insert it.
Press pad firmly to patient's bare skin.
All this I'll be doing compressions.
Stay clear of patient.
He said I should stay clear of patient. So I shouldn't be touching the patient. It's analyzing the rhythm. So it's analyzing the heart to see whether.
Stay clear of patient.
So it says shock is advised.
Shock now.
Shock is advised. So I should
Press the flashing orange button now.
press the flashing orange button now. Okay. So that's what I need to do. Okay. So at this point, when I'm about to press that thing, no one should be touching the patient. Because that is electricity that's going to go through this body. So if I'm touching it, it will shock me as well. So I shouldn't touch the patient. But this is a trainer thing, so it won't shock anybody. Okay. So I need to press that button.
Not press. Attend to patient.
Okay. So I delayed in pressing it, so that's what it told me. So once you press it, it will say shock delivered. Resume chest compressions. So once immediately you press on that button, just come back and start your chest compressions. So you do the chest compressions, and it will, as you are doing it, now you don't need to count again. This thing now would count for you. Let me go back to that so that you will see exactly what happens.
Stay clear of patient. Analyzing. Apply pad. Plug in pad connector next to flashing light. Stay clear of patient. Analyzing. Shock advised.
Okay.
Stay clear of patient.
Shock is advised. Stay clear of patient.
Deliver shock now.
Deliver shock now. So I deliver the shock.
Shock delivered. Begin CPR.
Begin CPR. So start the compressions. Now, look at the rhythm. So it's now giving me how I should be compressing. So now I don't need to count. So I'll be doing this up until it will tell me to stop the compressions, for it to analyze the heart rhythm again, to see whether the pulse is back or it's not back, and whether I need to continue the compressions. So that's what will happen. Okay. Whilst it's doing that, let me just say a few things. These parts, you can't attach it if the person's chest is wet. You have to dry the chest of any water or anything before you attach the parts. Okay. If you have some, at times some people have some medicine patch on their body for pain or something like that, you need to take that one away and clean the area dry before you attach the parts. Okay. If there's so much hair, the men, too much hair on the chest, this thing will not stick. Let me listen. Stop CPR. Stay clear. So it's analyzing the rhythm. no shock is advised. So once they say no shock is advised, you're not going to press anything because it won't even come for you to press. You just have to go on and do your compressions. So all this while you'll be doing your compressions, these things are still attached. You don't remove them. They are still attached and you do your compressions. Okay? When there's so much hair on the chest, these things will not stick. So you need to shave the hair. They will say that if you have two of this, you use one, you yank it, the hair will go off. You yank it, the hair will go off, then you attach a second one. But Mother Ghana, we have only one. We don't have two. So we will shave the hair of the chest and attach the one there. Okay? So that is about the AED. Okay? That's about the AED. No, that's the reason why we are teaching you. You should be able to know how to use it. That's why I've demonstrated it here. Ideally, this chest room, we should have one here. And it's not far from us. We should be able to buy one here. Anywhere people converge, there should be an AED. So, you should stop CPR. Stay clear of patient. It's analyzing the rhythm. No shock is advised. So I need to continue the compressions. Okay? So we go back and you do the compression. So it will keep doing that up until the pulse comes or you get the patient to a hospital. And when the pulse comes, it will say no shock is advised. But you need to check for the pulse to see whether the pulse is back. Okay? So that's basically about the AED. It's very simple to use. Very, very simple, just as you've seen it. That's the same way you do. You get it, you power it on, you obey its commands. That's all. Okay, question? Yeah.
Is this the same as the one they use, like the iron?
So that is the manual defibrillator, and usually they are in the hospital. That one, when you are using it, you need to be able to see the rhythm and say that shock is that you would now decide, okay, I need to deliver shock. The machine won't tell you, okay? But it's automated. So it's able to analyze the rhythm and tell you shock is advised. No, so actually they say that one is more effective than this one. Because that one, you can select the energy that you must give. This one has one energy that is giving for the adults. At times they have smaller parts for kids. But other than that, you can't change the energy. If it's not working, you can't change the energy. But adults, you start, if the energy is not good, you increase it. Yeah, so, yeah, that is better than this.
So what do you do if the person has a pacemaker? Can you use
Right.
the AED on the person?
Yes, it can be used, just that you don't attach the parts over the pacemaker. You need to move the parts a little away from where the pacemaker is underneath the skin. But you can use it.
So if you don't know someone has a pacemaker and the person goes into cardiac arrest and you do this, you are literally killing the person.
No, you will not kill. So what I'm saying that you can use it for a patient who has a pacemaker. Just that, the pacemaker, they put it underneath the skin. And you don't want to put this part over it because the energy would go through that. You don't want to do that. If you don't know.
So usually when you see a
Yes, you can see
pacemaker
it.
pouch,
Yeah.
so your skin, as you would all see, there's nothing on your skin there.
Yeah.
When you put the pacemaker there, it's like
A matchbox or something.
a matchbox.
Yeah.
Yes. And you see that there's a
Bulge.
bit of a bulge
Yeah.
on that part of
Mhm.
it. And depending on where it is, it may be on the left, on the right. So if it's on the right, just like where you have put this part, you put it below
it.
That's yes.
Not on the
The
pacemaker.
pacemaker is just a device that sometimes we need to give to some people to help their heart to beat. So some people have it.
Yeah. Yeah, so see, once you expose the chest. Yeah. And this is on the bare chest. So you would have exposed the chest so you would see. Yeah. Any questions on the AED? Because that's basically about the AED.
And your AEDs are available. You just have to sometimes ask. Some of your big hotels have AEDs. It's sometimes because we don't know. So at least off the top of my head, Alisa Hotel has one. Lancaster has one. Some hospitals, Bank Hospital, IMA, there are a few other places. They have AEDs. You just have to ask if something happens around there. Somebody may be able to help you. Your airports, they have that.
Am I supposed to get some at home?
If you can afford an AED at home, it's fine. But really, what we would need you to do is start the CPR.
Yeah.
The CPR is life-saving. This
Yeah.
chest compression, we can't overemphasize it. It is life-saving. The earlier you start, the better it is for us to get the patient back and for us to continue the rest of the care.
All right.
Please, is it the equipment the doctors use on the football field when a footballer went into cardiac arrest?
Yeah. Anywhere there's cardiac arrest, this must appear there. Yeah.
I just want to add that we are going through this session for us to know how to use the AED. There was an incident at the airport where somebody came off the flight and had a cardiac arrest. There was an AED, people didn't know how to use it. So we are equipping you with this knowledge so that in case, wherever you find yourself, you may be able to save a life. So let's not take that for granted. It's so important. Thank you. Yeah, the person died actually because no one knew how to use the AED.
All right.
When we were demonstrating, it was assumed that the ambulance would bring this. But in case this is already available at the time of the cardiac arrest.
Oh, yes. You quickly reach out for it. So when you call for help, if there's one there, you tell them they should bring the AED. So I call you and say, oh, Mr. Freeman, bring the AED. You bring the AED and attach it to the chest, and we take it right from there. The automated external defibrillator. Because it's that long, we have to shorten it. And by the time we finish saying, the patient is dead. All right. So I don't know whether you end up with a choking or you put it the other one.
No, I think we'll quickly do choking and then, so maybe just the next extra 10 minutes, we finish choking and then we should be done. Hopefully we have answered every question that we have. So we can take our seats now and then we'll just go through choking.
Yes. Okay. So I guess it's quite, this is quite similar to the child and the infant, just that usually they will put one in front and one behind, and it's smaller parts that they would use, okay? So let's briefly talk about the choking, and then we would end it. So I'll start with the adult, and she would do the infant one, how you do the back slaps and stuff like that. So someone is choking, probably they ate something. I mean, choking means that there's something in the airway, not that you ate fufu and a chew minimum. That's not choking. In the medical terms, the chew minimum, that one is not part of it. It must go in the airway where it's going into the lungs. That's where the choking bit comes. So you have air come from your lungs out for you to speak. So when someone is choking and the choking is complete, they cannot talk. If it's incomplete, they can still talk and they'll be coughing. If it's incomplete like that, you ask if they are coughing, encourage them to cough whilst you call for help to come. Okay? So if you call for help to come, if they are coughing, encourage them to cough. If it's complete and they cannot talk, they hold their neck like this. And you ask them whether they are choking. They can't talk, so they will say, they will nod. Are you choking? Then they are not. You know that this person, he needs help. Okay. So I'll demonstrate with Joe. So he is the one choking. Okay. And I need to help him. We do what we call the abdominal thrust. Okay. Also called the Heimlich's maneuver. In that big name, it's not necessary. Abdominal thrust is all that is necessary. So you make a fist. Okay, you make a fist. And you're going to support that fist with this other hand. So I wrap my hand around him. And I'm going to stand like this. You look at how I'm standing. My one leg is in between his legs. I stand like this. Okay. In a position that if he's falling, I can easily lay him on the ground. If I stand behind him like this, and he's falling, we'll go back together. So I need to stand behind him like this and lay him gently to the floor if he's falling. Okay. So my fist, it goes above the navel. Okay. Just above the navel, but not into the chest yet. I mean, just above that. I support it with this other one. And I'm going to push in and up forcefully. So I do that until the thing comes out or until he collapses. Okay? Because I can't do it on him or his banku will come out tonight. But that's what you do. You stand behind him like that and then you do it. You do it. Forcefully upward. I mean, you do it forcefully until it comes. Now, if my hand can go around him. If he's too big, obese, and my hand cannot go around his tummy like that, I do it on his chest. I wrap around on his chest and I do the same thing. Okay, that's what I do on his chest. It goes for if the patient is pregnant. Because if you're pregnant, you can't go and put your hand on that womb and do that. You just rupture the womb and the baby will be dancing in the abdomen. Okay, so that's not what you do if it's pregnant too. So obese, so a pregnant man and a pregnant woman. You do that on the chest. Okay, that's what you will do. Okay, and then for the infants, let me get you the mic.
So for the older child, you can do the Heimlich maneuver, what he just did with Jojo. Another variation for the child is between the shoulder blades.
The shoulder blades.
You can.
Let me hold it. Okay.
So you lean over like that, and then you give.
Back slap.
You give back slaps. So with your heel like that, and then so back thrust, so like hit and push. Okay, hit and push. So you can start with that. If it's not working, then you can come and do your Heimlich maneuver. So that's for a child and an older child. For the infants,
sit. Let me draw the chair. Sorry.
So you sit. You hold the child on your knee like that, and then you are going to do so. It's a combination of chest thrusts and then back slaps. So as you are doing the back slap, the child is on your arm like that, and your finger is opening the mouth and supporting the head. So like that. So you keep the mouth open, head supported, and then in between the shoulder blades, you are hitting like that. So you give 5 back thrusts or back blows, and then you turn the child over onto your other arm, and then you do your 2 fingers chest thrusts, 5. Then you repeat.
So as you do it, the thing is not out. You do the back slap 5 at the back, then you turn, and the chest, just like you were doing the compressions, you do the compression with 2 fingers like that.
So you are also looking to see whether maybe the thing is coming, 2, 3, 4, 5. Then you go back. So
1,
you keep doing
2,
it.
3, 4, 5.
So you keep doing it till it comes out. But in the event that the child collapses or loses consciousness, then you go to your CPR. What we did. So your chest compressions, 30 compressions is to 2 breaths.
Yeah.
So this is what you do for infants. So hand on your knee like that. So dominant hand. Put the child over your arm like that. Keep the mouth open, head supported. 1, 2, 3, 4, 5. So you are doing this motion, trying to push it up and out. So like that. 1, 2, 3, 4, 5. Then support the head, flip over. 1, 2, 3, 4, 5. Then repeat. 1, 2, 3, 4, 5. Okay, so that's what we are doing till it comes out, or till the child goes unconscious. But we are hoping that it will come out. So for them, you don't do Heimlich, no. Yeah, so that's the difference.
So the other thing I didn't say is when Kojo was falling and I lay him on the ground. Once I lay him on the ground, now he's unconscious. I don't check for pulse. I don't check for anything. I go straight and start the chest compressions. So I do 30 compressions. When it's time for me to give the breath, I look in the mouth. If the object is in the mouth, I sweep it out. If I don't see it, I don't put a finger in there. Okay? I just give my breath and I come back and do the compressions. Then when it's time for me to give the breath, I look in the mouth again. That's what I will be doing when he collapses and he falls down. Okay. I think we'll take the last round of questions and that should be it.
I think I was going to ask, What if somebody has not had a cardiac arrest but a respiratory arrest? What do you do?
Okay, yeah, that we didn't say. So there are conditions that will let somebody have the pulse is there, but they are not breathing. You know, when the people were overdosing on the tramol, they were getting respiratory arrest. It's one of the drugs that can let your breathing stop, and then your heart is there. When it does that, you just give them rescue breaths. That's what we call it, rescue breaths. You give them 6 breaths in a minute. No, sorry. Every 6 seconds, you give them 1 breath. So it will be around 8 to 10 breaths in a minute. Every 6 seconds, you give them a breath. And you would have called for help. And help should be coming. So every 6 seconds, you open the mouth. If you have the pocket mask, you put it on. You blow in them. And every 2 minutes, you check whether the pulse is still there or it's gone. Because if the pulse goes away, you need to come back and start the chest compression. Because this time, she's saying that the pulse is there, is the breathing that is not there. So you just support the breathing. But every 2 minutes, you check whether the pulse is still there or not. If the pulse is not there, you start your chest compression. Other than that, it's just the rescue breath that you give. Every 6 seconds, you give 1. Every 6 seconds, you give 1. That's how it goes.
Sorry, a bit of education. I think probably while we've got the opportunity, I can share. There are times where we have the ambulance, you know, and we are driving on the road and the ambulance wants access. And I see a lot of people not moving, and this ambulance needs to get a sick person to the hospital. One day it could be anybody in that ambulance. So please always make way for the ambulance to pass. Don't say that, oh, maybe it's an empty ambulance and oh, maybe they just want to dodge the traffic. Maybe they are rushing to go and pick another patient who needs urgent attention. So please, I'm just encouraging all of us, when you're on the road, you are driving, or you're in someone's car, you're on a trotro, encourage them to make way for the ambulance, because you could save a life. Time is of the essence. Thank you.
Yeah, my own experience when the ambulance was sending my husband to Kolebu, is between life and death. So no matter what, you have to give way. I've learned that during the process. So it's between life and death. So we should take note of that.
Okay, so we'll just go over the steps again. Can somebody tell us so that we know that you remember the sequence of events? So somebody collapses, what do we do? Just a recap.
Oh, I just want to, we want to make sure we've all understood what, so you meet someone on campus, or you came to LIC and you saw someone at the car park lying on the floor.
What will you do?
What would you do?
You want to be sure that the person is breathing. And you also want to find out if the person has good pulse.
So what's the first thing you would do when you see someone lying? Okay, so I think that's
the safe scene.
The safe scene. You need to make sure that the area you are going to attend to this patient or this person is safe. So make sure there's no oil there, you fall yourself, water there, you slip on, glass on the floor.
Electricity.
Make sure that that place is safe. Okay.
What's the next step? So now your scene is safe. Next step.
Maybe before you call for help, after ensuring that the scene is safe, what would you do?
Responsiveness. You check for responsiveness.
Okay. So she talked about checking
Yes,
for responsiveness.
so how do we check for
how
responsiveness?
Would we do that?
So if you know the person,
You call the person's name.
okay, if you don't know the person's name, what will you do?
If you don't know the person's name, what would you do?
There's one more.
Hey!
I like the way we are emphasizing the beat. Because if you don't know the person, please beat the person. Please beat the person.
Okay, and after you do that, no response, what are we going to do next? We have called the person, we have tapped. Please, if it's a baby, are you going to shake? So, all right, so we've done our tapping. Person is still not responding. What are we going to do next?
You check for pulse and breath.
Okay, so where are we going to check the pulse?
Here, then you shift to the side.
All right, if it's a
Then use the back of your
small
palm.
child or an infant, where are we going to check? All right. Or the groin. All right, okay. So we've done that. There's no pulse. Person is not breathing. What are we going to do next? What are we?
So what's the next thing we will do? You had to call. No response. Then
person is not breathing. There's no pulse. What are we doing next? Call. Okay,
Call
she
for
says
help.
call for help. Okay, and when we are calling for help, who are we calling? Area macho man. Who are we calling? Okay, and what's the number? Okay, and then the other number that was provided on the. Okay, great. So we've called for help. What do we do next? Hey, you should have exposed the radio. How did you see the chest was rising? So we are going to start. Okay, where are we going to compress the stomach? Or
the middle area in between the nipples, if it's a man.
so the breastbone. So a line between the. If it's a woman. If it's a woman.
I think you put 3 or 8.
Is it the nipple
The
that you
breast,
used in the
and
woman?
then you put the 3 here.
No.
Try and estimate halfway of the bone, and your hand should be a little below that. 3 fingers, I think.
Okay. Any other approach in getting the point in a woman? Hey, that means the women will help them all. Because we don't remember how to help them all. But please, did we all hear what he said? Oh. Please, can you repeat what you said for us? I think they didn't hear.
I said halfway between the bone on the front. That's the sternum, I think they called it. You estimate halfway, and then you be on the lower half. And that is where you place your dominant and the heel of it.
So another way is from the bottom here, the bottom of the breastbone. That's where you do the 3 finger breaths. From the bottom of the breastbone. Okay, and in an infant, upwards. 3 finger breaths upwards. In an infant, where are we going? Yes, so same nipple line, but just a little below the nipple line. Okay, great. So now we've located our landmark. How are we going to do our chest compressions?
You use the dominant hand, the heel of the dominant hand, put it there, and then you use the other hand to support it, interlock, and then you start pressing.
What other things are you supposed to ensure before you start pressing?
Make sure your elbows are straightened and your shoulder is above.
Okay. So we've done all of that. Then what do we do next? What's the next step? Your shoulder is over, your dominant hand interlocked, shoulder is over. What next?
You do 30 compressions, counting out loud without your heel getting off the chest, but allowing the chest to rebound, if I can call it that.
Correct. Okay. So you are doing your 30. You do your 30. What next?
2 breaths.
Okay. All right. 2 breaths. And then when you finish, then you stop.
You come back to the breast, the compression.
So when you finish, you come back to the compressions.
Then
Okay.
you go back to the breathing. You take a deep breath before you blow it.
All right, great. For children, is it different? Is it different for children? How is it different for children?
You can either use your, oh, you mean the cycle? The cycle is the same, but the holding, you can either use your 2 thumbs whilst holding the child across the chest, like the way you are doing, or you can use your 2 fingers like that to do the pressing. If it's an older child, you do it just like you do for an adult. No, I don't remember which other one. Or one, yeah, the dominant. And,
Okay, so I think we've gotten our sequence correct. Please, at the end, if you want to come and try the choking routine, you can try.
Thank you so much. A round of applause for Dr. Kwame, Ekremet, Maame Ofori-Asumadu, Dr. Jojo Ayi, and Auntie Christiana Wowi. Thank you so much. A round of applause for them again. They've been patient to take us through all of this. In another time, this is like a whole day session that they've been able to abridge it for us in just a few hours. So thank you so much. God bless you. What will happen is that I think we'll put together some of the things that we've learned and some of the emergency numbers, and we'll share it as part of the recording that will be shared on all the platforms. So thank you very much. We'll call Mr. Kudaji to close us in prayer.
Shall we pray? Our Heavenly Father, I want to thank you for an opportunity like this where we can learn from our professionals, the medical team. We want to thank you for all that they've taught us. We pray that, Lord, even as we go, we will be able to rehearse in our minds all that we have seen and heard. We also pray that we will be careful to share with those who are not here what we have heard, what we have seen done, as a way of making sure that this thing sits with us and we understand it better. We pray that, Lord, as we go to our various homes, you take us safely home. We pray that, Lord, you get us home so we can rest, have a good rest for tomorrow, so that those who have to go back to work or other assignments that we have tomorrow, the rest of the week, Lord, you would grant us the ability to do this. We pray that, Lord, as we go, you go with us. We ask all this in the name of our Lord and Savior Jesus Christ. Amen.
Amen. Shall we share the grace? Before we share the grace, thank you, control team. They've been really, really helpful. God bless you. And everybody else who helped behind the scenes to put all of this together. As we came, we saw that everything had been arranged nicely. Lots of mannequins that were arranged. So, and there were a lot of people behind the scenes who put all of this together. So God bless everyone who took part in this, who contributed. So shall we rise and share the words of the grace? The grace of our Lord Jesus Christ, the love of God, and the sweet fellowship of the Holy Spirit be with us now and forevermore. Amen. Give somebody a lift. There are some who are going out of campus. So if you are going out of campus, please give someone a lift. Thank you very much. God bless you, team.
Our heart is an amazing organ. It works hard for us every second of every day delivering blood and oxygen to every cell in our body. But when sudden cardiac arrest strikes, our heart suddenly and unexpectedly stops beating effectively and blood flow stops. Without any intervention, the brain, vital organs, and our heart will begin to die. Beginning CPR is the person's only chance of survival. Brain damage will start to set in within 4 minutes, and after 10 minutes, brain damage becomes irreversible. The power to save a life is truly in your hands. Performing CPR accomplishes 2 critical things. 1, compressions move oxygenated blood to the brain to keep the brain alive. And 2, compressions keep blood and oxygen moving to the heart muscle itself, so that it has the best chance of resuming a normal electrical rhythm after a shock is delivered. As you begin compressions, you are creating an artificial pump and doing the work of the heart manually. With each good, effective compression, you are building up pressure in the system, which will move blood around the heart and up to the brain. It does take time to get the blood moving with CPR, so it is very important to push hard and push fast to build the pressure up, which keeps blood going to the brain. Pushing down at least 2 inches allows for the heart to be squeezed and blood to move out. Pushing at a rate of 100 to 120 compressions per minute is necessary to keep blood pumping. Let's see what happens when we take our hands off the chest. Blood stops moving to the brain. It is for this reason that if you are taking your hands off the chest to deliver breaths or switching roles, it is critical to minimize time off the chest. Watch what happens when we don't push deep enough. Blood does not reach the brain. The same is true if we do not push fast enough. Watch what happens when we push too fast. The heart does not have time to refill with blood, therefore not enough blood gets pumped out. Watch what happens when we don't allow the body to decompress and allow the chest to fully recoil. The heart does not have a chance to refill with blood, therefore no blood gets pumped out. So remember, the key purpose of delivering compressions is to keep oxygenated blood moving within the heart and up to the brain to keep the brain alive. We need to push hard and push fast in the center of the chest. If ribs break, that's okay. What's not okay is allowing the brain to die from a lack of oxygen. So remember, you are their only hope. Do the best you can and don't give up until medical help arrives or an AED is present. You can do it.